And and I'm going to pay attention to, I have a lot that I want to share with you, but I definitely want to have time at the end so that we can have a conversation together about the kinds of experience you have and the questions on your mind. But I'm going to give you a sense of how I think about depression in later life, and I'm a geriatric psychiatrist at Johns Hopkins. And it is a very big topic and one that I spend a lot of my time with and seeing a lot of patients. I don't have any disclosures to make. And in terms of my objectives for our talk, I hope that by the end of the talk, you'll be able to identify different types of depression that could present in older adults, that you'll be able to discuss about how you might detect depression in an older person who has dementia and how it might look a little bit differently, that you'll be able to discuss factors that increase risk for suicide in an older adult, and you'll be able to discuss some effective ways that to treat depression and support older adults who do have a serious depressive disorder. So start out with, I think the first question is, well, how common is depression in later life? And you might think, well, that's a straightforward question, should be easy to answer. It turns out it's a little more subtle because it depends on how you define depression and it depends where you look for it. So in the 1980s, there was a very large community survey study that was done where they sent these interviewers out into the community and did a professional, excellent, high quality interview with older adults just living in the community. Actually, it was part of a study that looked at adults of all ages, and they wanted to find how prevalent is major depressive disorder. And they were shocked that major depression, while it's probably higher in adults in general, maybe 5-6%, major depressive disorder was actually 1-2% in adults living in the community. And that didn't quite make sense because we know that we see so many older adults who are depressed. And yet, if you looked in other places, like in medical primary care settings, this is with for medical purposes, or patients who are hospitalized on acute medical services or surgical services, look, the rates of major depression are much higher, and in nursing homes even higher. But what's this category? This is very interesting. If you define major depression not by a DSM-5 criteria, but by something else called subsyndromal depression, which I'm going to talk about next, you'll see that the rates of depression are much, much higher in older adults in every single one of these different settings. So what is this subsyndromal depression? So basically, it's on the continuum with major depressive disorder, where the hallmark key features of major depression is a low mood and or a loss of interest and pleasure in things that a person has formerly enjoyed. And then we also look for other things: change in weight, usually a loss of weight to a decrease in appetite, difficulty sleeping, more slowed down, less energy, hard to concentrate, feelings of worthlessness, feeling negative about yourselves, and even thoughts of death. And all of these symptoms you'll see all of these that are characteristic of major depressive disorder are also characteristic of subsyndromal, but instead of 5 symptoms, we look for 2. So it turns out that subsyndromal depression is actually the most common mood disorder in older adults. And yet it's not a minor event. A quarter of the time, people actually, without intervention, without treatment, will really change and look worse within 2 years and really have a full-blown classic major depressive disorder. But even at this level of subsyndromal with 2 associated other symptoms, it really impacts function and quality of life. And because we consider it to be on the same continuum with major depressive disorder, we do treat it similarly, so that we might, for instance, treat with psychotherapy, cognitive behavioral therapy, and then if someone really is quite incapacitated, we will probably use antidepressant medications as well. When we're thinking about depression, though, what comes to mind, of course, is you're probably familiar with major depressive disorder. Could be a one-time event, could be recurring. Sometimes people have psychotic features like delusions or hallucinations. Could be subsyndromal depression, But I also want to point out to you that older people have depression associated with other conditions too. Bipolar disorder, which has the most common onset in when people are younger and in their 20s or 30s, never burns out with age. If you had it when you were young, you're going to have it as you age and as you become elderly. And as people with bipolar disorder get older, they tend to spend more periods of time with episodes of depression rather than mania. People can get depressed due to an adjustment disorder, an acute life event. Grief, we know how common that is, very common in older people. We don't consider grief itself to be a pathological condition, but some individuals who have persistent grief that they're never able to really move past and it really impacts their functioning after a year or so have what we call complicated grief, and that does need a psychologic and psychiatric intervention. You can have depression as a side effect of medication or as a result of substance use. You can have depression associated with dementia like Alzheimer's, and I'll talk more about it. And the last category is not depression, but just to say that sometimes when individuals actually have dementia, they might look withdrawn, less interested in things, and you might think, well, is this dementia or is it depression? And so it's a consideration that we have with older adults we don't think about with younger ones. And I'll talk more about that in a bit. So there are high rates of depression in patients who have particularly some medical conditions, and you'll see these medical conditions have really high rates of a serious major depressive disorder associated with them: Parkinson's disease, diabetes, cancer, Alzheimer's, and stroke. And these are all conditions that are much more common in older people than younger people. This slide is a little tricky to see, but it has a really important point that I want to talk to you about. The rate of depression after stroke, kind of to follow up with this last one. Oops, I said that up to 30% of people who have had a serious stroke will develop depression. And look at this as are you most at risk for having depression? And in this study, they looked at people here who'd had a stroke, and they compared them to people who didn't have a stroke, and they looked at 3 months, between 3 months and a year, and between 1 and 2 years after the stroke. The highest risk for depression after stroke was here in the first 3 months, but it was also high for the first year, up to the first year, and even high up to 2 years compared to a reference population who did not have a stroke. So there's something about stroke that predisposes to depression. The risk is high for 2 years, especially high in the first 3 months. And when there is depression after a stroke, there's an increased risk for mortality. And depression itself seems to be as well an independent risk factor, adding to the risk for mortality. So if someone has a stroke and does get depressed, you don't want to say, well, it's understandable, they had the stroke, they're weaker now, they can't function as well. And because it's understandable, now we understand why they're depressed. As a psychiatrist, I would say it probably is major depression and you really need to treat it. And we would treat it with the same, really probably antidepressants that we would in a person with a serious depression who did not have a stroke. But there are serious consequences for depression in patients who have medical illness. So we want to recognize depression in older adults because if they have depression and it's not treated, they will have a slower recovery from heart attacks, myocardial infarction. If they fall and break a hip or have some other fracture, they will have a slower recovery. They'll be less able and less engaged in rehab, which is probably why they have a slower recovery. If they're depressed and they're hospitalized on a medical service for any reason, they tend to have more leftover residual symptoms after discharge. They're less likely to follow doctors' recommendations for taking medication, adjusting their lifestyle, eating better. And overall, they have higher rates of general healthcare utilization. They make more outpatient medical visits. So there's lots of reasons why we want to be able to recognize depression and treat it. As well, depression increases the risk for mortality in older adults. And this is one of my favorite studies because it really makes a powerful point. In this study, they looked at three different groups of people and they followed them for 12 years. One group were people who were cognitively intact, no dementia, no cognitive impairment. The other third were people with mild cognitive impairment, some memory trouble, but not yet dementia. The third group were people with dementia. So these three groups of people they followed for 12 years. And they started off saying how many of them were depressed at the start of the study. And at the end of the study, were they still alive? Simple question. And what they found was fascinating, which is at every level of cognitive functioning, depression increased risk for mortality. What do I mean? Look at this pretty attractive slide. May be no surprise to me or to you. The individuals most likely to be alive at the end of 12 years were the people in red. At the start of the study, no dementia, no depression. And I would have thought, and you might have thought too, the next group that might be doing well would be those individuals who did not have cognitive impairment but were depressed. And that's not what they found. They found the next group that was most likely to still be alive at 12 years were these people. They had at the start of the study, they weren't depressed, but they had some cognitive impairment. And the next group most likely to be alive were the people at the start of the study who were not depressed but had dementia. Those who were at a higher risk for mortality were these people in green, purple, and orange, and all of them were depressed at the start of the study, including these individuals with no dementia, mild dementia, and more serious dementia. And so we see that having depression increased risk for mortality and had nothing to do with even whether they had dementia or cognitive impairment. At the same time, we know that having a serious depressive episode actually increases the risk for Alzheimer's dementia. And this has been studied in a couple of really important studies over the years. One that came out a little bit more recently that I like very much was published in 2018. And they followed almost 2,000 people over the age of 50, again, up to 12 years. And these individuals at the start of the study had a history of depression. And also, these are individuals who had mild cognitive impairment. And interestingly, they found that overall, about 40% of these individuals who'd had a history of depression did develop Alzheimer's disease. But the interesting thing was, the ones most likely to have Alzheimer's disease had an active episode of depression, which is about 42% within the past 2 years. Having a remote past history of depression increased the risk. That was seen in 32% of people, but having one that was really close to the time of the study increased the risk, and which suggesting that, and I'll talk more about this as well, that a late life depression is sometimes a trigger or the first beginnings of dementia, even before there's evidence of cognitive change. So we know that some people have depression early in life. It might be recurring of different times of their life, in midlife or late life. We know that there are some individuals who've never had depression, and now that they're older, they have a first episode of depression. Interestingly, in this group who's had a late onset depression, never had it when they were younger, they're less likely to have a family history of mood disorders. In these individuals, it's less likely to run in their family, so they probably did not inherit a genetic predisposition for it, like we often see in younger people. A late onset depression is more likely associated with changes in the brain related to cerebral vasculature and blood flow, suggesting that in these individuals, we see more atrophy of the brain, more reduction in certain elements of the brain that are important for memory, the hippocampus, and movement, the basal ganglia, and also probably evidence of tiny little mini strokes. So we believe the tiny little mini strokes are more likely to have a predisposed to a late onset depression. So with all of that, and knowing that this is a pretty obviously serious condition with serious ramifications, why is it often so hard to diagnose it and recognize it in older patients? And it often is. And I think that there are three main reasons why. One, is this aspect that so many older people also have other medical problems, which we call medical comorbidity. For instance, in a young person who's 28, 30, 35, if they can't get out of bed because they feel so slowed down due to their depression, or if they can't concentrate, or if they're having trouble with eating and they've lost an appetite, we're much more likely to say, "Oh, wow, something's wrong here. There's something serious. Maybe this lack of interest, maybe this low energy and slowing down is depression." In an older person, you might say, "Oh, well, maybe it's because of their chronic pain, or maybe it's because they have sleep apnea and they're not, or they have insomnia and they're not sleeping very well." So, in other words, because they have other medical conditions, some of their symptoms of depression might be attributed to those. Second reason, many older patients, when they're depressed, say, "I'm sad." But some of them don't say they're sad. They might say, "Well, I feel bad," or I don't feel right. They talk about malaise and they talk more in vague terms, and they might key in on a physical symptom, such as a stomach issue. I've had a couple of patients that every time they get depressed, they have terrible constipation, they have abdominal pain, and they focus on that rather than on a low mood. And so that also might uh, make it less likely to see, well, really what's going on is that this is part of a depressive disorder for this person. The third element is executive dysfunction, and we really don't see this in younger people, which is many older adults, when they develop a serious major depressive disorder, have trouble organizing, planning, thinking, functioning cognitively due to executive dysfunction caused by the depression. But the executive dysfunction, sorry about that, sometimes gets misread as dementia. It is not dementia because those individuals don't really have a problem with memory. It's really in the area of executive dysfunction, but it has a huge impact on their ability to care for themselves. Think about it. What do we need good executive functioning for? Well, we need it to cook. It takes a lot of executive functioning to plan and organize meals and recipes, make sure that you have the ingredients, plan and organize the different things on your menu are going to get done at different times on the stove. That takes a lot of executive functioning. I've had patients before, and in my practice, where maybe the wife developed a serious depression, and due to executive dysfunction, she couldn't cook anymore, and both she and her husband lost weight. When people have executive dysfunction, they make mistakes with their medicine. When they have executive dysfunction, they might not organize and pay their bills. So it's very important to pay attention to this. And part of the management of depression in older adults is not only treating the symptom of depression, but also finding out, is this impacting functioning due to executive dysfunction, and what do we need to do to help support them? The symptoms of late life depression are no different than they are for a younger person. I key in more on this one though, anhedonia, a lack of pleasure, rather than sad mood, because of the reasons I said before, that sometimes older people don't say they're sad, but they will lack pleasure, and this has to be very individualized. They will lack enjoyment and pleasure in activities they formerly enjoyed. If someone was always a sports fan, loved the Orioles, loved watching the Ravens, and now they couldn't care less, for them, that could be an evidence of anhedonia related to depression. If someone was a very doting grandparent, loved when the grandkids came over, had fun with them, and now they get on their nerves, they feel really irritated, they don't want the kids, that could be evidence of anhedonia due to depression for that individual. We often see self-depreciation and worthlessness, feelings of guilt. A patient that I once took care of on our inpatient unit was an older gentleman who had a PhD, and he was a retired engineer. And I wanted to call him, out of respect, Dr. So-and-so. He would not allow the nurses or the doctors to call him Dr. So-and-so during his period of depression, because when he was depressed, He said he never deserved his PhD, even though he had been awarded it 40 years earlier. And he felt that Johns Hopkins University had made a mistake. We see this in younger people too. We often see social withdrawal. We'll see changes in sleep and appetite, as we would see in a younger person. But again, these other elements may be more prominent in the older adult. The difficulty and confusion and difficulty following through due to executive dysfunction rather than a primary memory problem, as well as more somatic and bodily complaints rather than a low mood. I also want to mention that psychotic depression is not rare in older adults. And what are psychosis? That's hallucinations and or delusions. And delusions are pretty common. And the definition of a delusion is that it is a fixed, false, idiosyncratic belief. Fixed, meaning you can't talk them out of it, even if you give them a lot of evidence to the contrary. False, it's obviously not true. And idiosyncratic, it's particular to them. It's not shared by an ethnic group, or it's not a common religious thought. The most common psychotic delusions are paranoid ones, thinking that someone is out to get you or following you or going to harm you. Somatic, bodily ones. I've had patients who believe they don't have blood anymore. I once had an older patient with a psychotic depression who felt he no longer had an esophagus, that it had disappeared from his throat, and so he could no longer eat. Delusions of poverty, believing you're bankrupt, that you don't have any more money. Sometimes they could seem plausible. We know that older patients are frequently on tight incomes and they live on budgets. And so feeling you might need to talk to the family and to the adult children and find out, well, dad has plenty of money. This is a delusion. It's not something he needs to worry about. So it's very important to check this through and take a thorough history. I mentioned that sometimes depression and dementia can look similarly. In both depression and dementia, there can be a loss of interest, but in dementia, it's more apathy, meaning not interested in something rather than a loss of enjoyment, which is more characteristic of depression. In both depression and dementia, an older adult might not perform very well on an office cognitive test, but I often see as this is a little clue that individuals who are depressed just won't even try. They'll give up early. Whereas an individual who has a dementia will try, get the wrong answer, and not recognize the answer is wrong. And then again, the type of dysfunction is different. We see this executive dysfunction more prominent in depression, with impaired planning, organizing, and prioritizing rather than memory in dementia. And then one other point that can be helpful. You might have heard of sundowning, where people with dementia tend to get worse in terms of confusion later in the day. In depression, we see something called diurnal variation, where the mornings tend to be the hardest time. People can be discombobulated, disorganized, highly anxious in the morning, and actually feel a little better as the day goes on. To me, that often is an absolute clue that this is a serious depressive disorder. As a psychiatrist, to approach the diagnosis is always taking a very good history, not only from the patient, but this is crucial, from the family, a caregiver, someone who knows the person well, because I don't know them and know how are they really different now than their usual self. And because medical conditions and medications can also have changes in thinking or on mood, it's very important to pay attention to that. Very important to ask about substances, drinking and using other illicit substances. Our older patients particularly can have trouble with alcohol misuse and even cannabis misuse, which can affect mood. And then really also to do cognitive testing. As a psychiatrist, I also do some blood tests. There are a couple of medical conditions that can look like depression and you don't want to overlook them, such as a low thyroid condition, B12 deficiency, or sleep apnea. I want to say a couple words about detecting depression in a patient who has dementia. And before you might have remembered the slide where I said that depression is a risk factor for dementia, but also once someone has dementia, particularly Alzheimer's, about 20% of individuals with Alzheimer's get depressed. So, and in some cases, the reports are even as high as 30 to 50%. It's most common in the early and middle stages of dementia. We don't really see it in late stage. But we also see high rates of depression in other conditions like Parkinson's disease, which can cause dementia, Huntington's disease, which can cause dementia. And we want to recognize it because, again, this can affect quality of life, it can cause distress and worse cognitive decline. And yet there's an overlap in symptoms where you might see apathy, a loss of interest in activity, social withdrawal, difficulty concentrating and thinking, lack of interest in yourself. And these could all be symptoms just of the dementia. So it can be hard to say, well, is there now a depression here as well as a cognitive impairment? Interestingly, when it's been studied, we do believe that when individuals with dementia get depressed, it's a little bit different than other kinds of depression in individuals without dementia. How so? Well, it does tend to be less severe. We do see less anxiety, less sleep and appetite disturbances, and also we see the symptoms might come and go rather than be more persistent. An individual who has dementia and depression is less likely to talk about suicide, less likely to attempt suicide if they have a more serious dementia. We do see more slowing, more fatigue, and we might also see a more rapid decline in cognitive functioning. The National Institute for Mental Health developed guidelines, now almost 20 years ago for how you might diagnose depression in people with Alzheimer's, and they really have not been updated, but it does take into account that the number of symptoms might be less, the duration and frequency might be less. They took out as a requirement a diminished ability to concentrate because that's a feature of dementia. And so this is sort of a summary, which is they would say to diagnose depression in someone with Alzheimer's, you'd want to see 2 weeks of either a depressed mood or anhedonia with 2 or more of these other symptoms, which could include social withdrawal, an effect on appetite or sleep, a change in agitation or slowed behavior, irritability, fatigue, feelings of worthlessness, and possibly thoughts of death or suicide. The question is, how should we really use this? And I would say it's only been studied in patients with mild to moderate Alzheimer's. We really don't know if this is really going to be helpful for those patients with more severe Alzheimer's. And in general, we find that that this is a suggestion, but there's really no gold standard. And also that probably antidepressants often are not the best way to treat depression in individuals with dementia, and they could actually tend to get better with improving their environment, trying to engage them more in activities. So there's a different quality to their depressive disorder. I want to move now and talk about suicide in older adults. And of course, we worry about suicide in all patients of all ages who have depression, which is obviously the most serious and worrisome outcome that we think about for any person who has a depressive disorder. When it comes to geriatric suicide, age-specific rates of suicide in the United States are really high among older people, and it's not uniformly high in all older people. The rates are the highest in elderly white men. Risk factors are having a serious depression that's not been remitted, being socially isolated. So widowhood is a risk factor in someone who's been with a partner or been married for many years. Substance use, either alcohol or other substance use, are risk factors. And also the last category, which is having chronic physical illness, multiple illnesses, like 8 or 9 or other multiple medical physical illnesses increase risk for suicide. This is a really dramatic slide, which shows the difference between men and women. And you can see that overall, the suicide rates are much higher in men than they are for women for the older age group. And interesting, this is comparing 2001 to 2021. So all the blues are 2001, all the greens are 2021. And over that period of 20 years, really not a big difference, right? And we're seeing for men, the rates of suicide by decade go up and up and up and are the highest for those who are 85 years and older in men. In women, there is an increase, there is a risk for suicide, but look, perhaps it's a little bit higher in the younger women. And as women get older, the risk is still there, but much, much lower. So definitely there's a difference by gender. This, I did mention to you that if someone has a moderate dementia, they're less likely to have suicidal thoughts and act on them. However, recent studies have shown that there is an increased risk for suicide in the first year after someone receives a diagnosis of dementia. And this is really worrisome because rates of dementia are going up and people are getting the diagnosis. A lot of people are interested in a lot of the new blood tests that can show whether you are likely have the brain changes associated, for instance, with Alzheimer's in your brain. It can be predicted by blood tests. So the rates of suicide risk in the first year are the highest among adults aged 65 to 74. And again, in the first 90 days after an Alzheimer's diagnosis. So it worries me actually about older people getting blood tests for dementia or for Alzheimer's disease. The recommendations are that you should not do it if you are cognitively well. It might be of use to do it it might be reasonable to do it after you have symptoms that suggest that you likely do have Alzheimer's, but should not do it for the worried well. And I think part of the reason why I absolutely agree is because of the risk for suicide. What else do we know about geriatric suicide? Well, this is an important point too, that among all adults, young people make more suicide attempts. However, among the older adults, there's one completed suicide for every 4 attempts, meaning that a geriatric suicide attempt is more likely to be lethal. And the reason why is that most cases of geriatric suicide in men and women are due to firearms. And this you can see in this slide that makes the point, and this is showing suicide rates among men. And the rates among men are really high at all of these different age groups for the use of firearms. Suicide by poisoning, which would be an overdose, suffocation, which might be hanging or something else, are present but much lower. So this really, the rates of suicide go up by firearms. And look, the highest use is here in this age group, which is age 85 and older. And this is different than the profile in older women. And in older women, there are significant rates of firearm use, but they go down by decade. And that overdoses are commonly used as well as the other mechanisms as well. So the profile is not quite the same, although firearms are used for suicide in older women too. So among the things to consider, though, is who's else at risk. And one of the things we found is that a history of a previous attempt elevates risk for suicide even decades into the future. So for instance, if somebody had had a suicide attempt at age 40 during a period of depression, happening in their life, obviously they survived and they got treated, and actually they're at increased risk for suicide even in their 70s and 80s because of that previous attempt. Second point, who else is at risk for suicide in our older patients? These people, those who are slow to respond to treatment, who they've been put on medication or treatment for their depression and they're still not well, they're still suffering. They are at highest risk. Having a sense of hopelessness, feeling I'm never going to get better, this is the way it's always going to be, increases risk for suicide. And again, having a chronic depression that doesn't get better increases risk. I also want to make this point that ageism might adversely bias against treatment. And I've seen a couple of studies where sometimes clinicians say, oh, I don't need to ask about suicide because this person is 75 or they're 80. I don't want to be disrespectful, and ask whether they're having any suicidal thoughts, or this person because they're a religious figure or because they're a community figure or the kind of job they have, making assumptions that they're unlikely to think about suicide. I call that evidence of benevolent ageism, which is having thoughts that are stereotyped just on the basis of age. And you might think it's coming from a good place, but it's never a good thing not to do a thorough history and ask people. We train our trainees and our residents and our young doctors. They have to feel comfortable at all ages asking sensitive questions about sexuality. People at all ages are sexually active and have sexual needs. And at all ages, if someone is depressed, we must ask whether they've ever felt so depressed that they feel life isn't worth living, whether they feel that they've had thoughts of wanting to harm themselves or take their own life. Because the opportunity to intervene might only happen if you ask the question. So now I want to move to talk about what are our current thinkings about treatment and management of older adults who have serious depression. Well, the first treatment issue I want to mention is the fact that antidepressants sometimes are not prescribed when they should be prescribed. And why is that? Well, I call it the quote, "you'd be depressed too" issue. So just because you think that what's going on in an individual's life could meaningfully cause depression doesn't mean that it's a serious depression that shouldn't get treatment with antidepressants. For instance, you might say, well, you'd be depressed too if you just had to sell your home that you lived in for 46 years and move to assisted living. Or, well, you'd be depressed too if you just had to retire from a job that you liked and now you're feeling more isolated. So just because we can sympathize and we can understand with the turmoil that someone might have, if they have the syndrome of major depression, whether it's associated with something going on meaningfully in their life or not, it's important to treat it with antidepressants. Second point, sometimes I see that older patients are on doses that are too low to get them well. A really important rule of geriatric treatment is we tend to start at a low dose and start at a lower dose than we would for someone who's younger. But we go up slowly over time, and the final dose is likely to be the same in an 82-year-old as a 42-year-old. Stopping at a starter dose is never going to get anybody well. Premature discontinuation, and really this happens at all ages, but in our older patients too. They get a printout from their pharmacy that lists all the different myriad possible side effects they may get, and they say, oh, I'm getting this side effect, it must be from the medicine. When in point of fact, maybe what was, quote, looked like a side effect was a symptom, like anxiety. So often patients who are depressed have anxiety as a symptom of their depression, and that's what the medicine is for. So mistaking symptoms for side effect. And then at all ages, these medications have to be taken every day, not occasionally at the same time. And in older people, as in younger people, as you know, there's a lag time. Our medications for antidepressants, all of them need to be taken 4 to 6 weeks at a good dose before people really get benefit. And individuals sometimes discontinue too early. So important key points are, while we might start at a low dose, we might increase the dose gradually. The final dose might be the same as a younger person. We always want to think about when we're prescribing for older people, we try to avoid too many medications. We try to think about how they might interact with the other medications that they're taking. But we give really all the same list of medications to older people as we do to younger ones. A lot of these names may look really familiar to you because we give them to older adults as well as younger adults. And I put here, what we might start with as a starting dose, but you could see the final doses are higher than the starting dose for just about all of them. Bupropion 150 milligrams is a reasonable starting dose, and it often is very effective at that dose. But really, and same with mirtazapine, but everything else like sertraline, very common antidepressant, you can stay at 25 milligrams for years and you'll never get well, whether you're 25 or 75. I also want to mention psychotherapy is important in helping people get over an episode of serious depression. And individuals do the best and have the best outcomes if they're taking medication and they're getting some form of psychotherapy. And it's really most critical in the early weeks, particularly in those first weeks of treatment before the antidepressant has really kicked in and it's reached its therapeutic effectiveness. That's the time when patients need to be engaging in psychotherapy, I think ideally on a weekly basis, so they don't lose hope, they don't get discouraged, they don't get demoralized. And they, during those early weeks, there's a lot we can do to help people. We can focus on practical problem solving, find support for them, encourage them. We can give them education about their illness, help monitor what are side effects, help them see what's a side effect and what's a symptom. Um, and also to continue to assess for the possibility of emerging suicidal thoughts or hopeless thoughts. Interestingly, at all ages, when someone gets treated with an antidepressant, not all the symptoms of depression get better at the same time or the same rate. The first symptoms to improve are sleep, energy, and appetite. The later symptoms to improve are mental, emotional well-being, and mood. And this is really important to be able to educate patients. In the early weeks, they might be starting to get better from the antidepressant and not notice it because what they're looking for is an improvement in mood. So perhaps a partner or a spouse or an adult child might notice, gee, wow, dad seems to be eating a little bit better or sleeping a little bit better or seems to be talking a little more easily, even though dad still feels horribly depressed. So it's really important to say, well, stay with your antidepressants. They're starting to work. Let's give it time. You're going to feel better in terms of mood probably in a couple more weeks. What do we know about treatment for depression in individuals with dementia? Well, as I mentioned before, unfortunately, depression in individuals with dementia really doesn't seem to get better with the usual antidepressant medications. We might try them, but a lot of the studies haven't been as helpful or as effective as we would like. So we tend to focus more of how do we help people cope with it? We focus more on this, behavioral activation. Try to get them to have a routine, to have activities, to be involved, to be socializing more, do some exercise, go for walks, play some games, interact with other people, and we get better results in coping with depression. What are other treatment modalities? Well, ECT, electroconvulsive therapy, is an excellent choice, and it would be the top treatment of choice if an older adult has a serious depression with psychosis, with those kinds of delusions I mentioned before, or for those individuals who are so depressed they're not eating, and maybe they're at risk now for malnutrition or dehydration. You've heard about TMS, repetitive transcranial magnetic stimulation. It does have FDA approval for depression. Right now, you have to have failed at least one antidepressant. Some older people do benefit from it, but in my experience, if they're very, very depressed, probably TMS is not going to be so effective. It's probably better for more of a mild to moderate depression. At Johns Hopkins, we are starting to administer ketamine or intranasal S-ketamine very cautiously with older patients to see who have very intractable and very, very difficult depressions. Again, I think the evidence base is just starting. We don't have great studies on this, so I think it's still there's still more to learn about it. But ECT, TMS, and medications and psychotherapy are not the only ways to help people get better from depression. And I want to mention these 6 points because they really are helpful at all ages and really helpful for our older patients. There's a huge value to exercise. Walking can be very beneficial at all ages. Sleep is huge. Getting 6 to 8 hours of sleep, prioritizing sleep, having a regular schedule. With my older adults who are depressed, I tell them to go off of their iPhones, to go off their iPads 2 hours before bedtime. There's a lot of evidence that the blue light that's emitted from these devices actually wakes up the brain and it's harder to fall asleep. Bright light therapy can be very helpful, phototherapy for seasonal depression, but sometimes it helps individuals who have non-seasonal depression, and I recommend it a lot. I recommended it a lot this winter. We had sort of a miserable winter. You might agree with me, and a lot of patients kind of get depressed in the dark gray days of the winter. And it's one of the nice things about phototherapy is that there's no drug interactions. It doesn't cause dizziness or insomnia. There are no side effects. So it's often a good adjunct. Trying to encourage people to have structure with their routine and to socialize and not isolate themselves is huge. And again, behavioral activation. It's so common for people to feel like, well, when I feel better, I will do such, such, and such. But rather, the evidence shows the opposite. It's when you engage in activity that it helps pull you out of the depression. And that's behavioral activation. And it works. So, a summary of what we've talked about here today: depression, especially subsyndromal depression, is common in older adults. And when it's there, it negatively impacts function, morbidity, increases risk for mortality. Anhedonia, not getting pleasure in things, having a diurnal variation where you feel worse in the mornings, a little better as the day goes on, having a more abrupt onset, and having executive dysfunction affecting your cognition helps to distinguish it from dementia. Treatment strategies are similar to the ones we see in younger people. ECT has the best evidence base, but don't forget a multimodal approach, including mobilizing family support, getting people to exercise, to be able to sleep well and not stay socially isolated. Well, that's the end of my prepared remarks. Thank you so much for listening today. I appreciate being here with you.
Dr. Lou, thank you so much. It's always so good to hear from you. Just the evidence base that you bring with your presentation. So, an experience, of course. So, thank you so much. I haven't seen any questions in the chat, but curious if anyone else does. I did have one question. Do you see any hallucinations? I know you talked about hallucinations maybe on one slide, but ever see any hallucinations that come alongside of with depression?
Yes, I think sometimes often people have more auditory hallucinations than visual hallucinations. They might be hearing. I had a patient once who was hearing voices of someone saying that he was being judged and he was in a courtroom and he was being accused of murdering somebody that he never murdered, that sort of a thing. So sometimes people will hear sort of negative auditory hallucinations saying critical things about them. That's true of all ages. I think the delusions to me are a little bit more common, but hallucinations too. Visual hallucinations are not as common. If someone is having visual hallucinations, it might be due to a delirium or might be due to a dementia.
Okay, great. Thank you so much. And you talked about dementia, which thank you so much for that. Um, do you see any similar symptoms or expressions from UTIs as well? I know sometimes with hallucination, I've heard members talking about with UTIs can often have hallucinations, depression-like symptoms as well. Do you see there a link at all there?
Right. So UTIs, urinary tract infections, you're right, are pretty common in older people. And in a younger person, it might just cause some discomfort. Whereas in an older person, it can really affect their thinking. In fact, I was just, earlier this morning meeting with a patient who told me about his wife who has Alzheimer's. And she just recently had a UTI. And when she had the UTI, she was emotionally distressed, more irritable, but she was also became delusional. And she became paranoid and thought her husband was going to divorce her. So we tend to see more, you can see sort of unusual thinking patterns, when she was abruptly different. And I think with dementia, we never see abrupt changes, but an abrupt change in someone's thinking and orientation, and if they're more cognitively upset, could suggest a UTI.
Yeah,
Easy to check. It's just a simple urine
sure,
test. Very easy to
sure, sure. Yeah, Danita, good to see you. Thanks for raising your hand. I can always count on you with a question. So love to
Hi,
hear from you.
Tara. Hi, Dr. Lemon. I as well appreciate you drawing the correspondence between depressions and cognitive disorder or challenges.
Right.
My bigger point is, and I'll be going into a master's for clinical counseling to focus
Okay.
in geriatrics because I have a degree in gerontology. So, to stay along that because I'm getting a lot of seeing what the need is for the caregiver and the person with the cognitive decline. How do you open the conversation for an evaluation? And I say this mostly to reference older adults who have gone into long-term care because the focus is always to treat the medical symptom, the chronic disorder or disease. How do we work that into the modality of diagnostics when we are trying to arrange what is going to be the level of care for that person?
Mm. Well, I think talking to the caregivers you're thinking about is absolutely essential. You
Mm.
know, family members, they often pick up on subtle things
Yeah.
that the clinicians don't see. I can't tell you how many times I hear about, someone saying, I mentioned this to my doctor. They thought I didn't have a memory problem or they thought I wasn't depressed, and the partner or the spouse did because they know them really well.
Yeah.
So we always want to listen to the patient, but I really listen to their partner, and take what they have to say very seriously, what their observations are, what do they see as different? Because they very often pick up on things that, that maybe the doctor doesn't see. Remember, doctors' visits these days are short. You
Yeah.
might be seeing a primary care doctor in 15 minutes at the most for a checkup, and there are so many things that they're going over. So, I think it's not as thorough as we all always wish it could be.
Mm.
So I think if you're listening to both, I think that's really important to be able to be an advocate to help. And then again, we know that even in long-term care and assisted living facilities, the rates of depression are high.
Yes.
It might be there because they have physical needs, that might be there because of memory needs, but the rates of depression are high. And so that, we want to be able to recognize them and treat them, give people the
Because
best
I see
quality of
that,
life.
yeah, I see that a lot when I volunteer at the VA for amputees. So my dad, over 65, combat veteran. And
Mm,
trying to explain to my brothers that that's a different level of care needed for
mm,
his mental health because you're contrasting these two things that everybody wants to lump in together, right? We're looking
right.
at someone who, at their time of service, there was no such thing as PTSD. It was just move
Mm,
on. As well as dealing with an amputation, they've already retired, they've already completely changed their way of life. So now you're piling on all of these things. And it is a different approach for veterans when dealing with chronic illness due to aging or subsequently having to have one of these procedures, right? Because you're dealing with the trauma and then the actual diagnostics and subsequent, medical surgical side of it.
yeah.
It's really quite interesting.
You're right about that. Well, good for you for pursuing which, the plans that you have. You're needed. Those skills and that knowledge base is so needed.
Dr. Lehman, question here in the chat regarding anesthesia. Is
Mm,
it a myth or is there some medical findings that anesthesia brings out the dementia or Alzheimer's more?
wow. No, it's not a myth. And so there's a lot of concern about that. I think good anesthesiologists take a good history to talk about what kind of anesthesia to try to keep it to a minimum. It can do really two things. I mean, I think general anesthesia sometimes can worsen confusion. Sometimes it's temporary and sometimes it's not temporary, particularly in somebody who has some baseline of cognitive impairment. So depending on the individual, they'll think about, is it possible to do the procedure with a spinal? Is it possible to do it with a local kind of anesthetic? Of course, major surgery is major surgery if somebody needs it, they need it. But screening people for cognitive impairment, looking at all of their medical problems and trying to tailor the anesthesia that will work the best for that individual and hopefully give them the best outcome is great, is the right approach. And I think anesthesiologists are really much more sophisticated about this today than they were years ago.
Wow, that's great to know. Thank you for that. Well, I know we have just a minute or about 30 seconds. Any last questions for the group? Okay, great. Well, thank you so much. I really, really appreciate you always coming and sharing such great information with us, research, and then, of course, your expertise. So thank you so much. And I hope that everybody else has a great rest of the day.
Yeah, thank you. Thanks for having me. It's been a pleasure to
Yeah,
be here. And thank you to all of you for all the great work that you do every day.
thank you.
Bye, everyone.
Bye.